Today we will talk about the third modality in the management of cancer is the chemotherapy. And we will talk about chemotherapy collectively. We are not concentrating about single drugs, but we will know the mechanism of action, how it works, what are the complications of the chemotherapy. And actually the chemotherapy making a tremendous improvement in the management of cancer. And there is a significant survival advantage when we use chemotherapy in many of the tumors. The main aim of using chemotherapy is to kill tumor cells. And as you see that this patient having a very advanced breast cancer, but it is poorly differentiated and rapidly growing. And when the tumor is rapidly growing, it will be a good target for the chemotherapy. So that when we started, we cannot do surgery in this patient because the tumor is quite big and the axillary lymph nodes are quite big. So that we started by chemotherapy first. And this is the picture after a few courses, and this is the picture after 8 courses. It means that there is a significant response of the tumor to the chemotherapy. As you know that when the cells are growing, when the cells are in the cycle, there will be a good response in the term of using the chemotherapy. So that when the tumor is proliferating, we apply chemotherapy and the tumor vanish or disappear or reduced in size, this will be a positive effect of the chemotherapy. This is our objective. This is what we need to do. But unfortunately, at the same time, the chemotherapy will affect other growing cells in the body, like the bone marrow, the GI tract, and other rapidly proliferating cells like the bone marrow. And this will be knocked by the chemotherapy, and this will make a side effect to the chemotherapy. So that in one part it works against the tumor, but in other part it works in normal growing cells. And this is a side effect. So that we have to weigh the balance between the complications of the chemotherapy and the advantages of the chemotherapy. And for this reason, we talk about a narrow therapeutic index, where the toxic dose to the normal tissue is very near or similar to the toxic dose to the tumor, which is a therapeutic dose. So that this is one of the major problems of chemotherapy, that it has a narrow therapeutic index. The mechanism of action, it is quite complicated. But we will talk in a brief about some facts regarding the mechanism of action of chemotherapy. As you know that the chemotherapeutic agents, you remember the cell cycle, and it is composed of phases. Most of the chemotherapy working differently in different phases in the cycle. And for this reason, when we use more than one chemotherapeutic agent, one working in one phase and the other working in the other phase, probably we will gain a positive effect from this chemotherapy. For this reason, usually it is advised to use multiple drugs rather than one single drug. As you know that the larger tumors are having a small growth fraction, and those tumors usually with big tumor and small growth fraction, so that the growing cells are the number or the percentage of the growing cells is small, so that the response will be less. Because big tumors usually there is a hypoxic cells. There is no enough oxygen, there is no enough nutrition going to that area, and those will be in the stage of G0, so that they will not be a good target for the chemotherapy. For this reason, we are unfortunate with the patient of the first slide, but usually when we have a big tumor like this, it is unlikely to have the response demonstrated in the slide. So that the smaller the tumor, the larger the effect or the impact of chemotherapy. In other ways, the smaller the tumor, the larger the growth fraction in the tumor. And the larger is the tumor, the smaller is the growth fraction. how the chemotherapy work in the term of pharmacokinetics. As you know that we have the mechanism of action, we have first order kinetic and we have, we have zero order kinetic and we have first order kinetic. Zero order kinetic means that a fixed dose of a drug will kill a fixed number of cells, a fixed portion, okay? While the first order kinetic, a fixed dose will kill a fixed percentage, not a fixed part or fixed number of cells. It is a fixed percentage of the cells present in that tumor. And we have a first logarithm cell kill where the fixed dose kill 90% of the cell population. And we have a second logarithm cell kill where the fixed dose will kill or destroy 99% of the tumor cells population. So that the mechanism of action of chemotherapy, it works as first order kinetic, second logarithm cell kill, okay? The chemotherapy, if you just see this slightly complicated slide, we have here the number of cells present in the tumor. You know that when we have number of cells 10 to the power 12, it is almost a kilogram of tissue. It is almost a kilogram. And we said before that when we have a tumor 10 to the power 9, which needs 30 doubling time to reach this number from one cell, and it has a 1 gram of tissue. So that from a few doublings, it will be 12 kilograms. So that if we start, for example, we're using chemotherapy with this bulk of the tumor. As we said that it is the second logarithm, first cell kill, when you start to give the chemotherapy, it will be reduced by 2 here, so that it will be 10 to the power 10, okay? But when we stop the chemotherapy and we will wait for the second dose, there will be a growth by 1 logarithm, okay? So that the end result at one cycle is 1 logarithm. Probably it is not easy to understand, so that we will, if we use chemotherapy, we just say that the remaining part of this is 1%, okay? 1%.
Yes.
يعني انتوا تعرفوا انه احنا لما بدنا نقول second logarithm يعني 99%، يعني 1 على 100، معناها احنا بدنا بس اللي نعمله انه 12 نقص منها قديش؟ 2. اوكي؟ فبتصير 10 to the power 10 and it will reach 10 to the power 11. When with the second dose it reached 10 to the power 9. So that from 1 kilogram, if it is unaffected, it will be a 1 gram of tissue. Before the second or the third course, it will grow again. Okay, it will gain 1 logarithm, so that it will be 10 to the power 10. And when we start the third or fourth dose here, it will be 10 to the power 8. So that when we have it, a 10 to the power 8 or 10 to the power 9 is a tumor of 1 centimeter in diameter. So that the tumor of 10 to the power 8, it is smaller. So that probably at this stage, when we try to detect where is the tumor, we will not find it. It means that clinically we cannot see the tumor. So that here will raise the dilemma after using this amount of chemotherapy. If we continue, okay, we will have therapeutic advantage. But at the same time, we will have a toxic problem, okay? So that if we just continue using this drug, at the end, in theory, we will have a cure. But probably the patient will die from using all of this chemotherapy. And other problem that the cells, they are not homogeneously responding to the chemotherapy. So that the patient will develop other cells resistant to this chemotherapy, so that this will bypass the mechanism of action and they will start to grow. So that for this reason, it is quite difficult to rely in solid tumor about the chemotherapy alone. While if we take a small tumor, which is micrometastasis, that we assume that there is a tumor, and probably it is a size of 10 to power 3 or 1,000 cells present in the lung or in the liver, so that when we use the chemotherapy, we will have a rapid effect and with a shorter duration, because the tumor burden is small. زي ما حكينا انه لما يكون التيومر small, كل السيلز, all of the cells are growing, okay, so that they will be hit by the chemotherapy. So that this is the concept when we have a problem whether to keep the chemotherapy and the patient develop toxicity and resistance, or to stop the chemotherapy when we don't see the tumor. But in a brief, when you finish the chemotherapy for a bulky disease, it is unlikely that the body is sterilized from tumor cells, okay? There will be dormant resistant cells. After the effect of chemotherapy, they will appear again. So that the toxic effect of chemotherapy will limit the dose. We cannot escalate. We have a ceiling using the chemotherapy. And cancer cells, as we said, showing resistance with time. And as we said before, that the virgin tumor, or balash virgin, the naive tumor means that the tumor didn't expose to the chemotherapy. At least we will have each 1,000 cell, one cell is resistant to the available chemotherapy. And with the use of chemotherapy, the tumor cells developing a mechanisms in order to get rid from the drug effect, either by making efflux, a mechanism which make efflux of the tumor outside the cell. The drug will come to the cell, and there is an efflux mechanism to send it to the outside the cell. And also there is a change in the process of apoptosis, okay? So that for this reason we will have the resistance. And the resistance to the chemotherapy, it is a real challenge and a real problem in using chemotherapy. The chemotherapy, how it works. The ultimate target of the chemotherapy, as you see, those are several. This is antibiotic, and an antibiotic, this is alkaloid-like. The main target is the DNA. Either will cause damage to an already established DNA, or making a cross-linkage which prevent DNA strands to separate, to multiply. But the major effect of chemotherapy, it is on DNA. Some of these cells, some of these chemotherapeutic agents may occur in the cell membrane. For example, the cyclophosphamide. They may work on organelles inside the cells, but the main target is the chemotherapy. Some of the cells are working on the spindle rays, okay, like the vinca alkaloids and the taxanes. And some of them, they work by inhibiting certain enzymes, like the methotrexate, which inhibit the dihydrate folate reductase enzyme, and the 5-FU, which work against thymidine synthetase enzyme. Now, the chemotherapeutic agents are divided according to their work in the cell cycle. They are having two major groups: non-phase dependent drugs, so that they don't depend on the phase. They work on different phases while the cells are in the cycle, and those usually are killing the tumor cells exponentially with increasing dose, so that when we increase the dose, there is the increase in the number of cells killed. But usually this will be associated with toxicity. Equally toxic, those who are not phase dependent, they are working on cells while they are growing in the cycle, or in resting phase, or in resting cells in G0. Example of these cells, chemotherapeutic agents, the alkylating agents, the cyclophosphamide, this is platinum, 5-fluorouracil, anthracyclines, mainly the adriamycin or doxorubicin. And we have what's called phase dependent, so that those are targeting certain phases in the cycle. And those usually kill cells at a lower dose, okay? And they act within a specific phase in the cycle, either in S phase or G1 or G2, or in mitotic phase. Example of this is the zinc alkaloids and the methotrexate. Now, why we try to know whether they are phase specific, non-phase specific or phase specific? Because when we use chemotherapy, we try to use a drug which works in any situation in the breast, in the cell. It means that either in G0 or in any phase, and we try to use another drug which is a phase specific. So that is the secret of combination. The drugs, we probably use a full dose of each drug if there is no potential toxic effect from giving both drugs together. If each one having a separate mechanism and a separate toxicity, probably we can use full drug, a full dose of drug from one of these phase non-specific and phase specific, so that we will gain therapeutic advantage. We will not increase the toxicity, and probably it will make the response and the control of cells much better. We will not go to have fine details about each of the chemotherapeutic agents, and you know that one of the main problems and the bad reputation of the cancer chemotherapy is its side effects, and its side effect is quite terrible. However, there are a lot of development in the last 15 or 20 years in order to protect against the side effects of these chemotherapeutic agents. One of the major side effects is the nausea and the vomiting of those patients, and usually there's now an effective anti-emetic drugs. But before the era of anti-serotonins, on the strong, usually the patients have a terrible situation regarding the nausea and vomiting. And usually the bone marrow toxicity, and now we have some drugs used to prevent this toxicity, and probably timing of the chemotherapy, which allow time for the bone marrow to heal. And we have the gastrointestinal toxicity, the problem occurring in the growing cells from the mouth along the GI tract, which is associated with nausea, vomiting, abdominal pain, diarrhea, and so on. And one of the serious problems for the patient from social point of view is the loss of hair. Okay? And another problem is the knocking of the ovaries in the ladies and the testes in the males, and this will make the patient sterile. It may induce menopause, okay, on those people, and probably the patient should be warned about this, especially if she is not married or she is planning to get children. And one of the problems also the hyperuricemia due to the liberation of uric acid, the end product of protein metabolism, when we have a bulky tumor, so that the uric acid is very high, so that it will give a gout-like problem and kidney stones. Some of these side effects are peculiar. What we said, those are general side effects of chemotherapy, but we have some peculiar for each drug having its own complication. For example, bleomycin, which is antibiotic, it induces pulmonary fibrosis. And the cyclophosphamide, it is famous to do what is called hemorrhagic cystitis. The patient will present with hematuria. Okay. And this comes through the end product of cyclophosphamide, which is called acrolein. And this acrolein, which is, it is the one which causes, it is an end product of cyclophosphamide, which causes hemorrhagic cystitis. And in order to avoid this, probably we can use chelating agents. What is its name? Mesna, methyl ethyl sulfonate. And we have one of the problems, this adriamycin or doxorubicin, it is one of the best drugs used to treat solid tumor. And usually there is a very good response in the majority of solid tumors. But unfortunately, this will cause cardiac problems in the form of cardiomyopathy. Many people, they have weak heart after having a significant dose of adriamycin, and the adriamycin dose is cumulative, okay? So that we cannot give the patient more than 450 or 500 per meter square as a total dose of adriamycin. Otherwise, we will face this problem. And usually there are certain drugs, but they are not commonly used in order to protect against cardiomyopathy, but it seems that this drug, they are not very effective in preventing this complication. Methotrexate, which is an antibiotic, also cause hepatic damage. And usually the patients get dark when we use 5-fluorouracil as treatment for breast or colon cancer. Now the response of the different types of the tumors is different. We have successful story in some tumors, and we have bad experience with the others. And we have more or less a response, but it is not up to what we think or what we need. For example, those are the tumors which are probably curable by using chemotherapy, like lymphoblastic leukemia, because you know that lymphoblastic is not a solid tumor. Most of the cells are proliferating, okay, so that will be targeted by chemotherapy. The germ cell tumors, testicular tumors, okay, those are very, very responsive to the chemotherapy, and you can claim cure from using chemotherapy in those people. Also the choriocarcinoma and the Hodgkin disease and Wilms tumor, and those are very responsive to the chemotherapy with a cure possibility. Other tumors, they have significant response, but the chemotherapy is not curable for them. But the use of chemotherapy is the cornerstone in the management of those tumors, in addition to the other local modalities like the chemotherapy and like radiotherapy and surgery. One of the tumors which are responding well to the chemotherapy is the breast cancer, but it will be as part of multi-modality treatment. And usually the ovarian cancer. Ovarian cancer are responsive, and which help the patient to survive longer than what previously they have lower survival in the past. Also, lymphomas, not all of the lymphomas are curable by chemotherapy, but some of them they show response, but it will not be 100% cure for them. And colorectal cancer, in the past, before 20 or 30 years, the chemotherapy to the colon cancer is not effective. Usually the people used 5-fluorouracil. But nowadays there are new drugs like oxaliplatin and topoisomerase inhibitors, irinotecan or topotecan. They are very useful in the management of colorectal cancer with a significant response. And osteosarcoma and Wilms tumor are responding to the chemotherapy. There are tumors which are resistant to chemotherapy. The chemotherapy almost useless in them. Probably they may respond, but we need large doses. And this large doses in a patient having pancreatic cancer, probably he is going to die before achieving any survival advantage. As we said that melanoma is resistant to the chemo and radiotherapy, some of the soft tissue sarcomas are responding to the chemotherapy, but the majority they are not responding to the chemotherapy, and the use of adjuvant chemotherapy or treatment of soft tissue sarcoma by chemotherapy is questionable. And you know that gastric cancer, also one of the bad diseases which is not responding to the chemotherapy. And you know that the hepatobiliary system, carcinoma in the hepatobiliary system, like gallbladder carcinoma, also they are not responding to the chemotherapy. You know that when we use chemotherapy, the port of entry of these drugs to the body mainly is through a venous system, okay? So that we put a venous line or temporarily a catheter, and the drug will be poured into the venous system, reaching different parts of the body. However, The chemotherapy can be given intra-arterial, as I said yesterday, in isolated limb perfusion or organ perfusion can be given intra-arterial. Drugs can be given intracavitary for patients having, for example, malignant ascites with multiple nodules in the peritoneal cavity. We can apply chemotherapy in the peritoneal cavity, and the major one used is the cisplatin, so that this will have a direct local effect in case of ovarian carcinoma, sometimes in mesothelioma, and sometimes tumors from the GI tract. It can be given topically, the chemotherapeutic agents, using the cream-like, and this is an example when we have a patient having, for example, skin tumors like basal cell carcinoma, but it is not very effective actually, but we can resort in some cases where the patient having zero dermal pigmentosa, if you know that those are having DNA problem in repairing damaged DNA by the viral trace, so that those people every now and then they develop malignancy, and we cannot do surgery all the time for them, so that we can use 5-fluorouracil. Sometimes chemotherapeutic agents are given intralegionally. For example, if we have a metastatic nodule in a patient unable to use systemic chemotherapy, sometimes we may inject chemotherapy, which it may have a local effect on those people. And the chemotherapy, by the way, can be used for other non-malignant conditions. For example, in patients with rheumatoid arthritis, people can use anti-inflammatory drugs, penicillamines, and then they resort to the low dose of chemotherapy. As you know that when we use the chemotherapeutic agents, when we don't have any evidence of the disease, a patient having CA breast, she's having T1 tumor, and she has no lymph nodes, we said that if the tumor more than 1 centimeter, we give chemotherapy. Why to give chemotherapy? Because we may have metastasis called micrometastasis in the lung or in the liver, so that we give chemotherapy without monitoring that if there is a response or not. We assume that there are micrometastases, and we assume that when we give chemotherapy, this will give a survival advantage to the patient. The chemotherapy can be used upfront chemotherapy or a new adjuvant chemotherapy. Is there any tumor? For example, this patient, she's having a big tumor here. We can start giving chemotherapy in order before surgery, in order to reduce the size of the tumor, so that this patient, instead of doing mastectomy for her, we do wide local excision. And when the tumor is that big, it probably 50% of the people we have distant metastasis, but undetectable. So that when we use chemotherapy from the start, we control distant or propose distant metastasis. We reduce the size of the tumor. We convert non-operable patient or patient needs mastectomy to patient needs smaller magnitude of surgery. And one of the things that you have a measurable evidence that there is a response. If you have start with this tumor and you give chemotherapy and this tumor disappears, it means that there is a complete response to this chemotherapy. Suppose that you give chemotherapy and there is no change in this tumor, or the tumor increase in size, or while you are giving the tumor there is a metastasis appeared here or there. It means that there is no response to those people, to this chemotherapy. And probably we need to change the chemotherapy, probably we increase the dose, probably we change the frequency and so on, so that we have to make a step in order to make a response in those people. Otherwise, you will resort to further local treatment like surgery or radiotherapy. Now, for the treatment of distant metastasis, so that this patient had a breast problem, for example, and after a while she developed metastasis in the lung. And this patient, she is candidate for a chemotherapy if she didn't take before, so that if she is chemotherapy naive, we will start chemotherapy. If she received chemotherapy in the past, and in spite of this she developed metastasis, we will give what's called second-line chemotherapy. And you see that the tumor, here we started chemotherapy, one of the lesions started to disappear, and here we have minimal appearance or remnant of the tumor, and in this photo that there is no evidence of a tumor. Now, if this proved to be complete response, okay, it means that there is no evidence of the disease. So it means when we say that a chemotherapy given and there is a complete response, there should be no tumor in the body. If this appears clinically, or by chest X-ray or by CT scan, we say that this is a clinical and radiological complete response. But if we have the chance to take biopsy from this site, okay, and we send it to the pathology, probably they will say that no evidence of tumor, probably they will say that there is a tumor. So that it means that there is a complete clinical response, but there is no complete pathological response. What is real, what is a fact is, which make a difference and in the pattern of the disease, is to have a complete pathological response. Sometimes, if we have a tumor, as I said before, if you know that most of the solid tumors, 40 or 50% of this tumor composed of non-tumor tissue, okay? And when you use chemotherapy, those are not targeted. The non-tumor tissue is not targeted. Probably they will be reduced in amount or in size. And at the site of tumor, we may have a scar tissue. We call it a healed tumor, healed site of the tumor, so that probably we will find some abnormality by radiological appearance. And when we take biopsy from this abnormality, we may find no tumor cells. It means that if the tumor radiologically present, it may be sterile. There may be no tumor cells, but there is a residual effect of the previous or an ex-tumor. So that presence radiological abnormality doesn't mean that there is no complete response. And absence of radiological abnormality doesn't mean that there is a complete response. Now we will go in a brief for the toxic side effects. You know that those are the targets of chemotherapy: normal tissue, the bone marrow, gastrointestinal tract, the ovaries, and the hair. Alopecia is one of the bad things that the patient will have, and probably most of the people refrain from taking chemotherapy because they don't like to be in this situation. However, not all chemotherapeutic agents causing alopecia, but the majority do. And usually, if the tumor causing alopecia, it means that it is effective up to the level of the follicles of the scalp. Some people try to protect the scalp from the chemotherapy. They use tourniquet, for example, or they may use a cold air, which at the time of chemotherapy they will be exposed to cold air, so that this will cause vasoconstriction, so that this will reduce the amount of drug goes to the scalp. Or they use what is called ice caps, okay, an ice-filled bag put on the scalp at the time of chemotherapy. This again will reduce the drug going to the scalp area. But one of the studies that patients with leukemia, and they use these modalities, okay, they have a complete response except in this area where they have leukemic nodules in the scalp. So that it's better when you need to treat it properly and try to overcome these social problems. There are many tips in reducing this phenomenon. For example, cutting of the hair very short so that the weak hair follicle will not have heavy hair or heavy weight, so that the effect of grafting is less, so that it takes time to form. Then also the scalp will be more sensitive. We can use shampoos designed for pediatric age group. And the people should be ready to use wigs before, and they can be ambulant. And sometimes in severe or in toxic doses or in heavy doses, not toxic doses, the eyebrows also hair is reduced cost. But the positive thing about this, that it's a temporary event. Okay, after finishing the chemotherapy, the hair will regrow again. Also, the other problem is the nausea and vomiting. And the nausea and vomiting, it has three things. There is a psychological influence, and we said that this anticipation of the problem and vomiting. We observe that people the night before coming to the chemotherapy administration, they will start to have nausea and vomiting. Sometimes when they come to the hospital, when they enter from the main gate, sometimes when they see lab coats, white lab coats, sometimes when they smell the smell of the hospital, they start to vomit. So that there is a psychological event in this situation. Also, the chemotherapy are hematogenic. They affect the vomiting center and trigger zone in the brain and induce central stimulation to these areas, and the patient will have vomiting. Also, the people have gastric upset. We said that the epithelium of gastrointestinal tract is shedding, and there is a problem of infection, and this may probably irritate the stomach and giving vomiting. However, nowadays, as we said, we have many precautions. Many people, they use the night before dexamethasone or corticosteroids, and they use the new modalities of anti-emetic drugs, plus minus the other metaclopramides. Also, the bone marrow is insulted. The bone marrow is insulted, and usually there is an effect on the platelets which may lead to the bleeding tendency. The white cells will be knocked down, and the patient more prone to infection. And red blood cells, the patient will be anemic with fatigue and general tiredness. Now the chemotherapy, when we start with the lower normal dose of chemotherapy, the blood elements start to be reduced within 6 or 7 days after the start of chemotherapy. And this reduction will go to the bottom, بنسميها the nadir effect أو الوصول إلى الحضيض أو القاع يعني القمة السفلية, and this will be appear in the 10 to 14 days, okay, and the recovery will start after that. Within 1 week time, the patient's bone marrow elements will start to recover, and he is due for the next course of chemotherapy. Now we have what's called the colon stimulating factor, granulocytes or granulocytes, monocyte colon stimulating factor can be given to improve the function of the bone marrow and to start early recovery. And usually platelets, they will not be reduced to bleed to make the patient spontaneously bleed unless we give high doses of chemotherapy where the platelets will be knocked to very serious level. Also, the anemia nowadays, the people use a colon stimulating factor, which is the erythropoietin, which improves the anemia in those people. The mouth ulcers also, those are a problem, making the patient unable to eat. Sometimes you need to use antifungal or antiviral treatment. Those people with good hydration, with good oral hygiene will overcome this problem. And usually, as we said, that upset in the shedding of the epithelium in the gastrointestinal tract, colonization with the new bacteria, make the people to have some sort of diarrhea. But some of the chemotherapeutic agents cause severe constipation because they cause autonomic neuropathy, especially the vinca alkaloids. Usually there is a loss of appetite, all of these things, chemotherapy, psychological element, gastric upset, stomach, oral ulcers, so that the patient usually they don't have a good appetite. And surprisingly, the patients on chemotherapy, they add weight because all the time they have sedentary lives, they don't have exercises, they eat more in order to compensate for the losses. The people take a lot of fruits, honey, and so on in order to improve their immunity. And the people sometimes significant doses of corticosteroids as anti-emetic probably participate in weight gain of those people. So that with chemotherapy, usually there is no weight loss, but there is a weight gain. As we said, we have to warn the patient that they have postmenopausal, they will go into menopause. Most of the ladies above the age of 35, the chance for their menses to come back is minimal. But before that age, there is a chance for them to resume the ovarian function. But it's very important to tell the people about this, and especially if they are planning to bring kids. One of the options in females is to take over, okay? And one of the options for male having testicular tumors is to take sperms and to put in the bag. And sometimes they make an embryo, a frozen embryo, and they will bring him back to the life the way they want, the time they want. Okay, thank you. شكرا. آسفين على التأخير.